Okay, hello everyone, and welcome to today's Journal Club. Briefly, we'll be discussing a consensus report from the American College of Obstetrics and Gynecology. And it's a fitting topic because you may not know, but today is World Birth Defects Day. Leading our discussion is Dr. Phil Molloy. He's a rheumatologist and continues to be active in caring for patients despite retiring. He fits us into his busy travel schedule. Dr. Jahan Marcu, a cannabinoid researcher and owner of Delaware Analytical, a research lab. And Dr. Len Kamen, we hope that he'll be joining us a little later. He's busy seeing patients. He's the clinical director at Moss Rehab Outpatient Center at Jefferson University and the president of the Pain Society in Pennsylvania and head of the Rothman Opioid Foundation. Next slide. I think everyone has joined us before, so I think that you're familiar with the company, that we have three pillars. Our research pillar is Salus, analytic pillar is Buds Info, where we collect a lot of information, and then Cerium is what brings the Journal Club. So it's really our education platform for healthcare providers. Next slide. And I have been checking, and I think I have a few new people who did scan the QR code and fill out the questionnaire. I greatly appreciate this. So if you want to take the time to do that. So, and Jahan, I think we have the Buds Info one at the end, right?
Correct. Yep.
Yeah, so I think that it'd be nice to kind of just like bring that up at the end in case anyone is seeing patients and they do have, I have been getting some reports, so that's great. That remains active. All right. And then the website is listed here below. Next slide.
All
Okay,
right.
I'm going to hand it over to Jahan and Phil.
Okay. Great. Well, welcome everyone. This is our Journal Club. So our mission and vision for the Journal Club is to support the education of healthcare professionals and discuss published research. I've said that enough times. I shouldn't be messing it up. Uh, just letting you know a little bit about our purpose here, right? Review and critically appraise published literature, discuss clinical implications, promote a professional exchange, and we do not advocate for policy positions, and we aim to evaluate evidence with consistency and transparency. Please share this link, whoever you got here, with your colleagues. It's the same link every month. We would appreciate that. So today's featured article is entitled Cannabis Use During Pregnancy and Lactation and was published by the American College of Obstetricians and Gynecologists. And it's from their Clinical Consensus Committee. And to start things off, we're going to start with some poll questions, just sort of about this study, about this research. If you have not read it yet, don't worry. This is just some anonymous, kind of true, false, yes, no type questions for you to answer, for us just to get a sense of a baseline reading. You should hopefully see it pop up now. It has questions like, cannabis use in pregnancy has convincingly been shown to be associated with negative outcomes. True or false? That's just sort of your opinion. It's anonymous. Don't worry, we won't be handing out grades or pass fails. It has 5 questions, one including I'm in favor of doing UDT routinely in prenatal care. That's urinary drug testing. Seeing some responses right now. A little getting some mixes. All right. Excellent. Seeing more come through. Really interesting balance here in question 2 so far. There is a perception amongst the general public that cannabis is safe, including during pregnancy. Seems like right now there's a little bit of a discussion around that. Interesting. All right, we will end the poll in about 10 seconds. Just want to we have over 80% responding.
Well, we have
Fantastic.
someone who wants to change their UDT answer. I don't know
Right.
if you can do that, right, Jahan? They can't redo it, right?
It's
No.
okay. It's pretty even, I would say. So they can let us know in the chat what direction they would
Perfect.
want.
Okay. All
So we're
right.
going to end the poll. It's all friendly here, so we're just going to share the results just to get a sense, right? So when we look at number one, cannabis use in pregnancy has convincingly been shown to be associated with negative outcomes. A little bit of a broad question, but we get some broad answers with it almost split 50-50 with true false. There is a perception amongst the general public that cannabis is safe, including during pregnancy. Um, Almost split 50-50 between the group as well. The ACOG guidelines are credible and will set the quote standard of care. We had looks like 70% said true. I'm in favor of doing UDT routinely in prenatal care. We see looks like about 60% said true and maybe about 40% said false. And number five, I'm in favor of documenting conversations with pregnant women on this issue of cannabis use. And we had, looks like 90% of the respondents said true or yes. Interesting, very interesting responses there. I definitely find it's interesting about our perception of the general public's perception of the safety or risks associated with cannabis. So all great stuff for us to discuss in a little bit. So moving on to Phil, do you want to talk a little bit about why
Sure.
we chose
Sure.
this study?
I'll throw my welcomes out. Um, this is an ACOG clinical consensus document. When it was published, it ended up in our inboxes. We scan articles on current stuff that relates to cannabis. They did this in 2017. I'm sure most of the audience here is familiar with that. So there was a previous article publication on this, and this one is meant to supplant and replace the previous one. And there's basically a couple of small differences. It influenced standard of care discussions, and it addresses important things that doctors do with their patients, screening, counseling. What should I write in the chart, and what should I not write in the chart, for example? So, next study, we'll go right into it. Next slide, rather.
Yep.
This is background. There's a lot of literature. I'm sure everybody in this audience knows this. There's a lot of literature out there on how many pregnant women use cannabis. So this is just one study. It's highest in the first trimester. It's commonly used for indications that have to do with sleep, nausea, headaches, anxiety, stress, the usual obvious things. By the way, when you do research or epidemiologic looking at how many pregnant women use cannabis while they're pregnant, there are two ways to do that to get the numerator, and the numerator can be done by urinary drug tests. So there are a lot of clinics that do UDTs on everybody, or you can use patient self-report. Do you use cannabis or opioids or alcohol or smoking, whatever? And most studies, if you read the literature, will test both nets, and a woman is classified as a cannabis user if either she self-reports or tests positive. But there is controversy on testing, as you'll see in a minute. There's a lot of studies like this out there. Go ahead, Jahan. We'll do the next one. This is background stuff. I think everyone here knows that THC and other cannabinoids, endocannabinoids, and phytocannabinoids and synthetic cannabinoids do cross the placenta. Use in pregnancy is the previous slide said 3 to 20%, 4 to 22. The reviews, you'll see all this stuff. Why is it an issue? Why are people using it more now than they did 1 or 2 decades ago? Your guess is as good as mine. Social normalization, you can see all the reasons. Perception of low risk is often quoted by patients and dispensaries. It's viewed as a natural alternative, and it's viewed as being safer than prescription medicines. In other words, I have nausea, I have sleep issues while I'm pregnant, I have anxiety issues. Cannabis is natural, And it's probably, I'm assuming it's safer than any prescription my doctor's going to give me. So we'll go to the next one. That prescription of safety is pretty well documented. So here's a flashback for those of you who haven't had a long history with the Cerium Journal Club. We began in early 2024, and in 2024, we did a three-part series on pregnancy, cannabis and pregnancy. Um, and the first bullet points are called traditional metrics, outcomes, pregnancy outcomes. Traditional, and it's been known for a long time, preterm birth, low birth weight, higher transfers to the neonatal ICU, lower APGAR scores, and so forth. They've been well documented, and there are review articles, and we have a reference if you want. Those are called traditional pregnancy outcomes. Successful, sort of immediately, you can know that by the time the woman goes home from the hospital, you can fill in all those boxes. Up until recently, no one knew if there was any long-term sequelae in the offspring, for example. Do these kids have behavioral problems? Do they have more ADHD? Do they have more anything as they get older? So it would be very hard, obviously, to do these studies, but it has been done by the ABCD study, a cohort of huge numbers, tens of thousands of pregnant women and their offspring. And now these offspring have been followed 10, 11, 12, 13, and now it's 14 years. And controlling for education, income, family history, and so forth. Now we're beginning to see that maybe there is. I don't want to go back and do this journal club over again from late 2024, but there are signals that there is a possible story there. So it was always known, oh yeah, there's some short-term stuff. It's harder to get pregnant, for example, if you're an active user. And there's other things at the top of the slide. But who cares as long as you recover and are fine when you go home from the hospital and you have your kid with you? Well, you do care if there is some long-term sequelae. And the last bullets are where do pregnant women get their information? That was the third article we did on our three-part series in the end of 2024 on pregnancy. Who do pregnant, a lot of interviews with pregnant women. Who do you trust? Do you trust your primary care doctor? Would you even ask him? Do you trust a bud tender more than your doctor? Do you believe, have you ever noticed a poster in a dispensary on pregnancy? Some states require posters in dispensaries and so forth. So it's pretty interesting on how pregnant women get their information, how they make their conclusions to support a decision. Am I going to use cannabis or not? So those were our three articles. And the next slide just gives you those references. And as Jahan said, are these also posted from 2024 on YouTube?
They should be. If not, they will be soon. We've been updating it regularly with the last couple years of journal
Yeah.
clubs. We
Yeah.
plan on creating a playlist with just
Yeah.
the cannabis pregnancy and development
Yeah.
series. But these are the
Yeah.
three studies that were reviewed previously.
Yeah. Very solid authors, highly respected, good researchers. So that's them. These are the articles. Go ahead, next one. So it's worth talking about consensus guidelines. How do you do a consensus guideline? First of all, with Cerium, we are attracted to randomized control studies, and we're straying today, obviously. This is not a randomized control study, which there aren't a lot about in cannabis in the United States anyhow, but it's we learn more from controlled studies. So this is not a meta-analysis, it's not a review, and it's not a control study. It's an expert consensus study. That said, they're very well regarded specialists. There's about a dozen specialists at ACOG lined up to do this. And they all did the primary research. They looked in all the journals that we don't have time to all read. So they put a lot of effort into this. They read 104 studies and they required 75% consensus. It was published and there are six recommendations. And they begin on page 603 if you guys have it. It's a free, I believe this is free. this article. It's open access. So let's look at it. Go ahead.
And here we have consensus recommendation number one.
Yeah, you can read it. Jay and I decided we're just gonna, the next six slides are six, they're six, the meat of the paper. We'll leave it up for a minute. And we underlined, the article didn't underline. Um, this is lifted right from the article, but there are no medical indications for cannabis use in pregnancy, and that there is no there's no professional society or approval for pregnancy, for nausea, for sleep, for anxiety during pregnancy. They don't exist, obviously. Most of the drugs we use have not been studied in pregnancy anyhow, as doctors. Most of our drugs are what used to be called category C. They're not known to be safe. They're not known to be not safe. They just have not been studied in pregnancy. We don't know. So
And
let's go
just
to
a
number two.
note, we
Yeah,
can come back to this slide later if a light bulb goes off and some neurons click together and you'd like to make a comment on this slide, but you're welcome to make a
yeah,
comment in the chat, raise your hand, or
yeah,
unmute yourself if you have a comment about this. But I think
yeah.
part of this recommendation, we can all agree that HCPs should be knowledgeable and educate all individuals presenting for pregnancy. And I think we could all agree on that.
Yeah, yeah. So let's go to number two.
Last thing I'll say is, there are no
Oh,
medical indications. It'd be real interesting to see how that is defined, maybe to go back, because accepted medical use is being debated openly right now in policy for cannabis and how that is defined. But it'd be good
my
to know
opinion,
what the
yeah,
metric is, because I'm sure you could find a medical society that would
yeah,
would support it, lots that wouldn't.
yeah. I
Um,
think they included that last sentence so they would have a quotable soundbite when this article hit the newspapers. I think that was the reason for that sentence.
Fair enough.
Speculating.
All right, and here we have consensus recommendation two. Again, we added the emphasis with the underlining of the words. Um, and I have a bias about this one. I think this one, to me, was one of the most important consensus recommendations they made, if not the most important one, is that HCPs should be aware of procedural, social, and legal consequences of positive screen results regarding, local policies, jurisdiction, the involvement of the authorities and child protective services, criminalization. I think that this is extremely important, and
In the
it's not only
discussion,
yeah.
yeah, in the discussion, it does allude that some states require reporting of positive urinary drug tests in pregnant women's to Child Protective Services. Not all states, but some states require it.
And I definitely think another aspect of this is HCPs being able to educate their patients and their clients and
Yeah,
their families about the social and legal and procedural
yeah,
consequences. They may not be
yeah,
aware. There are many
yeah,
people. I mean, we live in an age where they surveyed people about what the universal symbol for a product containing THC means, and they said, "Oh, it means it's legal. The government said it's legal." So
yeah,
we have people who are using these products regularly who think the warning symbol is an approval
yeah.
symbol from the government. So I definitely think there are some educational issues here as well.
All right, let's get through them.
All right, so consensus recommendation number three. Here they are recommending a universal screening process, interview, self-report, or some sort of validated screening tool for cannabis use. And very striking to me is that they suggest that biological tests should not be used as a screening assessment for cannabis.
That means urinary drug tests. For those of you who are wondering, urinary drug tests do not use urinary drug test. And what's missing from the top of this recommendation is advice on whether you should be writing it in the patient's medical record or not. So it's not addressed in this article. So yes, let's suppose I'm a doctor taking care of a pregnant woman, and I'm going to ask her by interview or self-report, or this question is, I'm going to ask her what is left unsaid in this. Should I write that in the medical record? He's clearly repeatedly said, don't do urinary drug tests. And then the last quote, by the way, on that one, go back one, where's, yeah, that one, number three. The last quote in the discussion at the end of the paper says, if you really, really want to do this test, get informed consent. So that's, I know it's inconsistent with don't do it, but if you decide your conscience makes you do it as a doctor or a healthcare provider, you should do informed consent because of the possible sequelae. So let's go to the next one. So a deeper look. Yeah, this is a deeper look. This is a second set of comments on recommendation number three for those of you who want to. And there's a rationale. If you download this article on page 605 of the article, will tell you the author's consensus recommendation of why they did this. To me, this is the most controversial thing in here is don't do urinary drug tests on pregnant women. So go ahead. And that's why we asked those questions in the poll ahead of time. Poke you to think about it.
Consensus recommendation number 4 from ACOG is that obstetric HCPs should advise cessation of cannabis use during pregnancy and lactation. However, they go on to say, and this is from the article, cannabis use is not a contraindication to breastfeeding, and breastfeeding should not be discouraged. So very interesting messaging there as well.
Okay. All right, I'm all set. You are?
Yeah, I think, again, this seems like a classic risk reduction, improving potential safety
Yeah.
outcomes approach. Consensus recommendation number 5. They recommend using motivational interviewing, addressing social determinants of health, and assessing barriers to cannabis cessation to guide cessation intervention strategies. I think that this is pretty straightforward. I think I would agree there should be more resources for this, especially if we're thinking about those procedural issues with screening, biological screening that may be required in some jurisdictions.
And the last one.
All right. Number 6.
For
They
those
are,
people who, yeah, show interest in cessation, you use those other things. Use everything on this list. Consider home visits, consider cognitive behavioral therapy, counseling, electronic test messaging, which is, to me, um, a controversial topic because when I was seeing patients, both of my clinics specifically had prohibitions against texting patients. Not discoverable, it doesn't end up in the medical record. Patient could say, oh, he told me this in a text, whatever. So it's just, I was prohibited in my clinics in the 2 towns I practiced in from using texting. Just
one
throw it
thing
out
that
there.
I'm not sure if brief electronic messaging counts as interacting with a chat bot or a generative AI, but there
Yeah.
have been studies that have looked at the power of hypocrisy in things like using intoxicants and driving. And they chat with this specialized chat bot to help them identify hypocrisy in their own logic or their beliefs or how
Yeah.
they approach things. And that is associated with potentially decreasing impaired driving or at least giving people that pause before they get behind the
Yeah.
wheel. So I wonder if they, Phil, did you see anything about them addressing these sort of AI
Oh, good.
chatbots?
If it's in there, I missed it, or I read the paper long enough ago, so I don't remember it. Yeah.
It's an interesting thing. I wonder. I guess that'll be their next year of consensus
Yeah.
recommendations. We'll
Yeah.
be looking into that use.
Yeah.
All right. Well, if you would like to chime in with a comment, either in the meeting chat or unmute yourself, raise your hand, whatever you'd like. What is your opinion on some of these updated ACOG guidelines? And
And if
we
there's
also,
one that they want to go back to and discuss further, I think maybe that's
Yeah.
also something.
While you're thinking about it, we have a few wrap-up slides on stuff that's going on right now and some food for thought
sure.
in a few slides here while you're thinking.
So here's one sort of mind munchie or some food for thought. So the original ACOG statement saying cannabis is risky in pregnancy was in October 2017. This one saying we should screen for it is October 2025. If it is risky, or it is if it carried the same risk in 2017, it is not implied it should be screened for. Why the 8-year delay to recommend screening? And
We can
and
go off of,
I wonder
yeah,
if it's a population question, maybe it's an epidemiology question. What happened
well,
in those 8 years? More states legalized it. More Americans live in a state where it is legal to access it in some form. And so majority of the population lives in a jurisdiction where
Yeah,
they can
so I have a
access
question for Phil because he read the whole thing. But Phil,
yes,
what is their definition of, did they define, because you did say in the beginning cannabis, the different cannabinoids, synthetic, like, so
yeah.
did they define it as everything?
Um, I don't think these guidelines defined it,
No, they
actually.
didn't. So they just
No,
used cannabis as
yeah,
as like a,
yeah.
I would say like a
It's ge
loose term
generic.
because
Yeah,
I guess Jahan, there's a lot of things that have changed, right, in the past 8 years. Um, Especially like to access, it says cannabis, but some people think that their CBD product is I mean, like we just don't know what they're thinking about if it wasn't defined in here.
yeah. I mean, I don't think Delta 8 and so forth was on people's radar 10 years ago.
Right, all of that, exactly.
Yeah,
And so
yeah.
um,
Well, my guess on this is that the authors of the consensus in 2017 could not agree, and so they didn't make a statement saying you should screen for it because they couldn't agree. That's just a guess.
right, right.
But
So let's
is there any knowledge of a effective non-biological screening tool that's been validated for the use of any cannabis product?
there are questionnaires.
There are questionnaires, but the validity of them, has that ever been tested? Because
Right, exactly. And that's
Yeah,
exactly right.
there's no
yeah,
No, that has not.
guarantee of veracity in any of the screening tools. It's just maybe an index or an indicator and say, and I just think this whole business is naive, and it's not really a thought conscious of reality, because people will have tendency to become not only tolerant but basically addicted to the use of cannabinoids, and it's absolute folly to think that just a simple tap on their shoulder saying this is risky for you, it's not good for you, is going to get them off of it. There's just not enough support for how do you make sure that people are not using or indeed aware of all the implications of using cannabinoids during pregnancy. I think there's a universality to this naivety saying that they should just screen for it, by asking people, because it's just not going to happen. It's just not going to change any significant amount of behavior.
No, well, it's the same with alcohol use, right? I mean, there's been so much research in
Right.
alcohol, and it's the same exact thing. And there's been much more research and, actual associations with the outcomes when you drink, a lot of alcohol during pregnancy. But so to your point, Len, I agree. No, you're not going to self-report that.
To answer one question in the chat room, I just went back and looked at the definition section of this paper, and it does not include hemp-derived CBD or synthetic CBD. That
And
was not part of this recommendation,
okay, so it
even
is
despite
specifically
despite the fact
THC.
that there, yeah, is information on
Yeah.
CBD.
And Mark has his hand up just in case no one sees that.
Yeah.
I can't find the hand
That's
logo, but
okay. I see your hand.
uh, thank you. Well, maybe I'm not reading this right, but I went over it last night and I was so happy. I mean, compared to the old one, this one's much more progressive. I mean, unless I'm misunderstanding, let's take the one that I noticed right away that blew my mind, and it could be a board question for residents and medical students, is of course you're going to advise them to stop cannabis use during pregnancy and lactation, of course, just like any other substance use. But for them to say that continued cannabis use is not a contraindication to breastfeeding and breastfeeding should not be discouraged, that's pretty progressive. I mean, let's think
100%.
about that. I mean, they
Exactly.
use, I mean, they're more advanced than psychiatry is on viewing this. So I was really kind of, I didn't even know that. So if I get a patient and, she's not quitting, I'm covering or something, and the mother's there and says, you got to tell her to quit. She's breastfeeding, that you can't do cannabis. So this is going to come up a lot. And I think it's very informative and useful to the clinicians. So I don't know, maybe I'm misunderstanding it, but with the caveat that of course you don't want them to do cannabis. But now let's get now what's underneath that. And then the
Right.
same thing with the screening after just you guys were discussing, this is very good because there's no longer get a drug test, now you're in trouble. But you can clinically use your skills. Of course, you're going to talk to your patient and screen, interviewing, reporting, discussing cannabis use. So, in a way, it kind of humanizes it another step and makes it less putative because, these morons aren't just relying on a drug test. So, I think that's very progressive. I would much rather screen my patients during interviewing and doing maybe some scales, whatever you like doing to screen somebody. So that to me is also very progressive. So anyway, I thought, and then the using the digital prescribing makes sense because they're doing that with most of the other substance of substance abuse, substance use disorders. You're going to have to embrace that. Okay, you got to get over the text messaging restrictions. I used to be like that when I first used electronic health records 15 years ago, 20 years ago. But the modern patient, you have to do some texting with them just to remind them of their appointment with your link to your virtual waiting room. Okay. So anyway, I'm very happy with this, and I'm going to include this material in my section on female reproduction. And one other thing is just to tie this with the previous SCC posting, for using cannabis in sexual dysfunctions, female sexual dysfunctions. It seems like it's going to be popular now, but remember, you're going to create a high risk you need to ask those patients, can you get pregnant? And you better talk to them equally about, now that you're hypersexual, what are you going to do if you get pregnant? If you want to promote the cannabis for sexual arousal and all that. So anyway, those should be coupled and discussed. And thank you. That's all I have to say.
Yeah, so I'd like to just go back to the breastfeeding comment because I was also kind of perplexed by that. By those statements because if you look at sort of the recommendations around breastfeeding, they put it in context with alcohol. So alcohol, you're supposed to like pump and dump kind of thing. It's out of your system in 6 to 8 hours, where cannabis can stay depending on and I am not an expert, right? But depending on the fat content and everything and the way that it was ingested, that it could stay in the system up to 6 days is what it says. Because I did look at this. Um, a little bit because of what you're bringing up, Mark. And the other thing is that what effect it does to the infant, right? So they say that the infant may get more sleepy, depending on because it is actually it is found in the breast milk. So it's not like it doesn't end up in the breast milk. It actually does end up in the breast milk. So it's an interesting thing to explore to your point, how they don't want us to tell our patients not to discourage breastfeeding, but that it's not a contraindication to breastfeeding. So it's interesting to me as well. I mean, do you have thoughts on that because of the timing versus alcohol? Like the recommendations around alcohol for pregnant women is pump and dump.
Yeah.
Well, if
Well,
I could,
I just think,
go ahead, Mark.
Well, I think there's a lot of good studies on the cannabis and the endocannabinoids in the breast milk, and then the animal studies with the pup, and then you give them a CB1 antagonist and they stop eating and die in 4 days. So there's a real crossover with the endocannabinoid system in the mother and in the baby, and it's very complicated and there's no simple answer. It needs to be studied because obviously it teaches the newborn how to feed and suckle and eat to survive the endocannabinoids. So eventually they'll catch on and realize it's important. But, yeah.
Well,
Right, but
to
there's also something in the chat, and we were talking about this before we started today around some of the cannabis use education and actually making it, that the conversation between the healthcare provider and the patient, and each patient is unique in their circumstances, and that should never always take precedence to, what else is happening, and what else they may be using. So I don't know if you want to elaborate, Christine, on that. Or maybe did she leave? I don't know. Okay. So
I think
so
she's
good
unmuted.
conversations. I don't know, Phil or
Yeah.
Len, if you have any
We
comments.
let's take some of those wrap-up slides, Jahan. We have a couple more
All
to
right.
finish it up.
Yeah. And again, you're welcome to chime in the chat or raise your hand or unmute yourself and hop in. Food for thought number two is it controversial to state UDT, the urinary drug testing, should not be employed? We kind of discussed this one already. So I think I want to move on to number 3 and 4 because we kind of discussed this and we come back to it. We also kind of discussed three, encouraging test
Yeah,
messaging patients is controversial. And in
yeah,
fact, some medical organizations prohibit it. But as we've had a participant say today, get over it. And you at a minimum, you have to use this to encourage people to show up to their appointments. You have to
yeah.
meet the average person where they're at to engage them in accessing their health care. And
I just want to say there's a difference between my secretary reminding you of your appointment tomorrow and me addressing a medical issue by text that belongs in the medical record.
fair enough. Number four, the use of language comment at the end of the ACOG recognizes and supports the gender diversity of all patients who seek OBGYN care. This appears to be an attempt to be politically correct, um, and overlooks that the gender of a pregnant person is rather obvious and does not need clarification. I think that um, not everyone, as already been discussed, not everyone who is pregnant identifies as a woman.
Yeah.
Uh, so I think whatever gets people to show up to their appointments, whatever makes people feel welcomed to engage in stuff that'll lead to better outcomes for them, if all we have to do is respect their wishes and things like that and how they want to be addressed. I don't see
Yeah.
what the harm is.
All right.
So I think that this is a bit of a cultural issue that, again, I think it's the same thing up there with electronic text messaging. For whatever reason, get over it and
Yeah.
accept the diversity of all people.
You can
I have a
also,
comment.
I agree about the medical not giving advice by text. In fact, I hate when my patients will get suicidal, as I'm a psychiatrist, and they'll tell me that, they'll text me, I go, you can't do that because I gotta call the police or something, I'm responsible for that. So we gotta figure out some kind of plan. It's a safety plan if that happens. But you can also, if it's important and you want to keep it in their medical record, you can take a snapshot of the text and then you download it into their records. And you can comment, see uploaded text from patient, states he was suicidal. So I called the police and had him go do a welfare, like that. So, you got to be a little bit creative, and
Yeah.
definitely you don't want to give advice like, oh, double your Prozac and call me tomorrow. You can't do that. Okay.
So Jahan Daniel had his hand up, I
Oh
think.
yeah,
Oh yeah,
please.
yeah. Hi everybody. Just a couple of quick comments. I'll try to be brief. I did not see in the article where they referenced the 2018 National Institute of Science and Engineering um, opus about how inhalation of cannabis therapy was more detrimental than oral cannabis when it came to preterm birth and birth weight. So I understand that, articles like this have to be generally broad and usually black and white, but there's a lot of nuance here. And I would predict that in the next iteration, there may be a comment on how the administration method of cannabis makes a big difference, and inhalation and oxygen deprivation and carbon monoxide exposure for a fetus is clearly, I think we all could agree, is much more dangerous than oral cannabis therapy.
Great point, Dr. Stein. I think that that might be a paper in and of itself is consensus guidelines for use of these products. I mean, there's so many products out there and delivery forms and formulations. And if you're going to use oral, what are some, what do clinicians even feel comfortable with using nanoparticulate something or other secret IP liquid formulation or just a THC in some sort of gelatinous cube. Um, I think that there are some questions around that too, especially with, people can take a product, um, do whatever they want to it, and they don't have to submit it to further studies like you would for an FDA drug, and then they can release it on the market the next day. So I think that it's worth. I guess my point is I could see people with a lot of information and knowledge in this area arguing over whether inhalation or oral administration is best and in what instances. But I think what are you actually consuming is an important conversation that is lacking from and difficult, I think, to convey in these types of papers. So I would say, yeah, that seems like they should just dedicate a consensus commentary to administration forms and clarifying that. I think that's a great point.
And dose, total dose. Dose matters, and in this era of increasing medical use and possibly decreasing recreational, or at least more education on reducing high dose recreational use. I think that matters, in terms of these outcomes for kids, in terms of adolescent behaviors and so forth. We may find that the medical use during pregnancy does have an indication in terms of harm reduction for eliminating opioids and other more dangerous medicines, hyperemesis gravidarum. I'm just thinking that there's a lot of nuance that this policy paper may not, can include, won't include. And as practicing physicians, these types of guidelines are actually not helpful in terms of medical legal risk, because if you don't do what the policy guideline says, then you're not practicing the standard of care. And so it's kind of a two-edged sword. I would emphasize that there's much more nuance to this question than is provided in this policy paper.
Yeah, I would agree, Daniel. I just go back and remember that before the tobacco companies were sued and lost their cases to the tune of billions of dollars to each state, we had no prepared materials in my office that would encourage people to quit smoking cigarettes. After that did happen, and there was money given to each state, and each state put some effort and some work into developing publications for public consumption on smoking cessation, we began to have some literature. Of course, I always say the governor got a new car and there's new guardrails on the streets, but we got these thinking little pamphlets. But we don't even have those pamphlets now. We have no literature to hand out to give to patients that might educate them as to dosing and to ingestion and inhalation risks. We have none of that material. There's no universal consensus of the marijuana producing companies that will have come forth and provided that to us. So as practicing physicians, I think it's naive. We're going to tell these people stuff that it's just going to go in one ear and out the other. Okay.
Yeah, great. Thank you, Dr. Kamen. I think that's a great point. It kind of shows us where we are, I think, with the cannabis industry, and maybe if it goes federal, hopefully there's someone somewhere who's working on future regulations that will have some of this tax money go to something such as that. But I think that
Right, and that's the public health
good use.
piece, right? I mean, I think that's really the challenge with anything and everything, that we're facing from, I'm not even going to get into it, but yeah.
Well, we don't
I
have to
agree
say it.
I
We
agree
don't
with
have to
Len.
say it. We can let the authors say
Yeah,
it.
there
All
we
right.
go. Okay, perfect.
And so this is, again, the author's words. Quote, "It would be potentially risky at this time to remain silent about cannabis use during pregnancy." Healthcare providers should be dedicated to learn more about this issue, keep it on their radar, and act in the best interest of our patients. And I think we can all agree on that. And I think their guidelines reflect this statement, their summary, and the implications they point out. And just in the interest of time, I'd like to get to some of the strengths and weaknesses as we wrap up the Journal Club time here. Of course, still open for comments, questions. Happy to go back to any slides quickly. Strengths and weaknesses addresses an area of importance. The authors are credible. They use consensus methodology. I think that's a big strength. Some weaknesses, no new primary data presented, no sort of analysis, no attempt to compare cannabis to alternative treatments for the distressing pregnancy-related symptoms that people seek out treatments for. And I think so we heard some other comments in the Journal Club today. One that just, again, is top of mind is discussing about dosing. We had a lot of comments in the chat about delineating different types of products more quickly. You can buy cannabis products that have CBD in them, or those could be classified in legal speak as a hemp product, but they all come from the cannabis plant. So definitely some disentanglement there with when we say don't use cannabis, or when to monitor it, when not to monitor cannabis use. We still need to define a little bit clearer what use is. So this is a active area of research. There's lots of basic science, new stuff coming out all the time. There is clinical research that's coming out regularly, looking at everything from exposure to a bigger focus on advertising and retailer information about inhalable products such as cannabis and tobacco products. And a shameless plug for Dr. Phil Molloy and myself is that we contributed chapters on cannabis and the developing brains textbook edited by Hilary Marsac. And I have a chapter in there on cannabis and education. And Phil, I think you wrote directly to this topic, right?
The title of my chapter is How to Have Conversations with Pregnant Women About Cannabis.
Yeah. So if you check out the textbook, some of the chapters and summaries may be available online. And we just like to, as we reach the end road here, talk about that. We are talking about risks and benefits here, and that is the best way really to discuss. And that risk-benefit ratio, I think, is often overlooked. And what were you talking about with this, Phil? You had a great statement. One thing we should consider.
Well, often overlooked. We all are obsessed with risks and benefits for any medicine or drug or substance. But what is often overlooked is what's the alternative? And for a pregnant woman, I think she has two alternatives to cannabis. One is conventional drugs, which scare her if she reads the package insert. And the other is to do nothing and suck it up and live with your distressing symptoms. And when I think this way, it gives me more empathy to my patients. And I like to say, in a traditional drug, I don't know what to write in the medical record when it comes to cannabis, to be frank with you. But if it wasn't cannabis, I would write down, I went over all the risks and benefits and alternatives, and I support the patient's decision to do what she thinks is best for her right now. I'm not sure I would write that in there about cannabis, but it's my attitude anyhow. And that's why we put the risks and benefits, including doing nothing, which some women are going to find unacceptable.
So our next journal club will be Tuesday, April 7th, and we'll be discussing a article that is more in the basic sciences. So we're going to go to some basic science roots, talking about the endocannabinoid system and sort of the pathophysiology, some of these hypotheses around attention deficit hyperactivity disorder, and some of the data that's out there that might talk about some mechanisms, some animal research, some clinical research. I think as a basic scientist, I think these are the most fascinating discussions. So I hope you'll join us, and you don't need to know anything about conducting experiments on rodents or petri dishes to learn and participate and comment. We welcome everyone to put on your lab coats and join us for that discussion. And in May, we are looking at tackling, I think, a tough issue, or I guess tough data, and that is some new data on mental health and high potency THC products. We were discussing in our green room before we came into the Zoom room about some of the more recent JAMA articles on THC and the risk of psychosis and other mental health outcomes, and just the difficulty in parsing through that data, understanding that data. How is it collected? What are the strengths and weaknesses? So we hope to bring you a discussion of that on May 5th, Cinco de Mayo. Bring your non-alcoholic margaritas, and we can have a fun discussion of some really interesting study designs and help us break down some of this data that grabs the news media headlines. All right. Well, one last thing. I'll just throw this up there. This is our Cerium questionnaire.
Yeah, go to the next one, the Buzz
All
Info.
right. Yes. Here's our
Thank
Buds Info QR code. Free service that tracks adverse
And
events.
pregnancies. If you find someone who's pregnant on cannabis, like that's considered by the regulatory definition an adverse event. So if a patient becomes pregnant, they're using cannabis or any in CBD product, anything, it'd be great for you to have them scan the QR code. Thank you in advance. All right, Jay.